percentage that for reimbursement? Like,
Let's go back for a second.
Okay.
Let's talk. Okay, so we've got the primary function of insurance. That's the first thing. Like they don't discuss it in school. And I always say, like, if you are going to explain to a 6-year-old what is the function of health insurance, generally speaking, what would you say? How would you describe it in like 1 or 2 sentences?
so I would say health insurance is a way
Yeah.
to yeah. So like the words that I mean, without even just trying to think and come up with something.
So
I'm thinking like it's how you protect yourself from from going to debt because of a huge bill. That's where I go.
So to paraphrase, and come over here just so we can kind of talk and I can get this. So health insurance, the way you describe it is a form of protection, financial protection, in the event that you have some sort of catastrophic health event and you need some way to stay out of bankruptcy and cover those costs. That's kind of what you're saying.
Yes.
Of course, a 6-year-old's not going to understand that. The way I would describe it is essentially it's a group of people that come together and make an agreement. They say, hey, every month we're going to throw money into this pot. And at some point, one of us is going to have a problem. And when that person's entitled to the money in that pot. You know, so if 10 of us put $100 into this every single month, and at the end of 10 years, one of us falls and breaks a leg, that person can use the money here to pay for the casting and the splinting and all the other stuff that they need for the broken leg. The other 9 have lost the money they put in. You know, I mean, that's basically what it is. Everybody cannot take money out of the system. There has to be a majority of people that put money in, lose that money, never get that money back, so that a few can benefit. Now, nobody knows who those few are going to be going into it, but it's a financial tool. That's it. There's no emotion, there's no feelings, there's no insurance company that's trying to take advantage of anybody. When you purchase your insurance plan as the consumer, you did it based on a combination of you didn't pay attention to the cost as much, and you said, these are the benefits that I want covered. The more benefits I want covered, the higher, like normal. I go to a car lot, I buy a nicer car, it's going to cost me more because there's more benefits in that car. Again, it's a financial tool. You know, it's regulated by the government just like a bank account is. There's really no difference. There's no human emotion. There's no judgment. It's you and I make a decision. We write a contract. That's what it is. And so what's important is people need to understand there is no good or bad insurance. It's not. It's I pay more. I get more coverage. I pay less. I get less coverage. I assume more risk. My monthly premium is lower. And so when we take that now and we go to the consumer, the patient who's sitting in front of us who says, I've got terrible insurance, I have a $50 copay with every visit. Okay, well, it doesn't mean you have terrible insurance because you know what? You're saving 10 or 20 bucks a month on your monthly premium. And the example, did I share the example of my mom's story? So this is a really interesting way to look at it. I don't think we look at it this way. So when my mom first was going to Medicare, she had the option. She can go with Medicare Part B, and she had a monthly premium, and then 20% co-insurance that she would be responsible for, but she could get a supplemental. So she looked at the cost of Med B and the supplemental, and then she looked at the Medicare Advantage plans. And so she could get off of Med B, go to Part C, which is Medicare Advantage. And there's different plans there. And so you could have your PPO, you could have your HMO. The HMO is the lowest cost, but there's also the least coverage. And so she was upset because the plan that she ended up going with cost $10,000 a year, right? And she didn't go to the doctor and you know, she was, so keep this in mind because this is going to come in later. She was a type 2 diabetic. She was hypertensive. Other than that, generally healthy. You know, active individual, business owner. Okay, so she gets a Medicare Advantage plan. She pays $10,000 the first year. She's irate because she didn't need any medical expenses. Okay. Year number 2, she pays $10,000. Year number 3, she pays $10,000. Year number 4, she's $40,000 into this policy, and really has received no major benefit from it, right? Year number 5, now her diabetes has progressed consistently, her hypertension has progressed consistently. She goes on dialysis, right? She's still supposed to be managing the diabetes with oral meds. She's not managing it well, hence the dialysis. She's on her way home from a dialysis session. She's driving herself to and from. She passes out. She gets into a car accident. She crashes into a car that's parked on the side of the road. Nobody else gets hurt, thankfully, but she gets hurt. She gets admitted to the hospital, CT scan. She's got a brain bleed. She's, at that point, she went to the ICU. So she has an ICU hospitalization. Then she transitions to like a skilled nursing. She gets discharged back to home. She has another incident. She falls while she's at home. She goes back to the hospital, goes back to skilled nursing. I want to say there was a third admission. Eventually, she's non-responsive. She's non-verbal. She's like a classic case of, I can't think of what they call it when somebody's not eating and they're losing weight and they're not responding. There's a term for it. But anyway, and so she ends up passing away all within a year, right? Now, sad story, sounds terrible, years ago, but the idea is that in that year of life, she probably spent $500,000 in medical costs. She paid in $50,000 over a 5-year time frame. So absent of the emotion, if you look at that and you say, what other investment can I put in $50,000 and be guaranteed an unlimited, especially now that they've removed lifetime max. You know, I've got an unlimited potential return on that investment. Now, nobody wants to get it that way, right? We'd rather get it in the stock market and go live on the beach, but that's the reality. And in order for her to pull $500,000 in coverage after paying $50,000, how many thousands of other people had to pay into that policy so she could get the benefit that they didn't use? That's what health insurance is. So when you look on the website, when you go to buy your health insurance as the consumer, we have to understand we're buying an investment, just like if I buy a share of McDonald's, just like if I, put money in real estate. I'm buying a financial tool, an investment. There's certain guidelines, certain regulations. I have to pay my premiums. I have to do these things. But the return on that investment is virtually unlimited at this point. And then the second side. So when the therapist comes to me and they're like, this is ridiculous. United Healthcare only allows $50 reimbursement per visit. They don't understand the value. A physical therapist can save tens of thousands of dollars by avoiding surgery. It doesn't matter. They don't care. Like, that's not their role. When you, the consumer, buys a United Healthcare policy, I can almost guarantee when you look on the website and you're choosing between United Healthcare, Anthem, MedMutual, Humana, United Healthcare has the lowest monthly premium. What goes into that, the reason why they can have that lowest monthly premium is because they have negotiated on your behalf. You're the consumer. You hired that insurance company to go and negotiate the lowest possible rate of reimbursement so that you can save on the front end. You don't have to pay as high of a monthly premium because that insurance company went out and will reimburse $72, United Healthcare $50, Medicare $105, right? Those different reimbursements for the same service, the provider makes that choice. Now, as a provider, if they come to me and they say, Tony, we have 100,000 beneficiaries in our network in your area. We're only accepting 3 therapists in your area. There's 100 therapists. We're only going to allow 3 in network. Well, that means 3 of us have access to 100,000 beneficiaries locally, right? High volume. If I'm in that business, then I'll take a $50 reimbursement because the volume is there. Now, let's say like MedMutual comes into the area. And MedMutual says, well, we have 20,000 beneficiaries, not 100,000. How are they going to get me to sign I'm not going to sign for $50 because I don't have the volume. So they say, okay, we're going to pay you $75, right? And it's just normal negotiation. It's demand and supply, but we lose sight of that. And we think that there's a human on the other side that's like, well, physical therapy, we can take advantage of them. We're going to only pay them $50 because that's all that is. No, like nothing to do with that. The third aspect, right? This conversation. Cool. You're coming out as a professional, you're licensed, you're going to be working, you're going to have an income. You're probably going to have a 401k. You're probably going to have some sort of investment vehicle. And when you look at that, you're probably going to be an owner of United Healthcare in some capacity, right? If there's money in the market, there's probably money in healthcare stocks at some point. And so if United Healthcare doesn't turn a profit, you and your 401k do not go up. So even though you're getting paid less on the front end as a provider, that money's flowing back through in the form of investment income in your portfolio, in your retirement account, you know? And so if United Healthcare wasn't profitable, they wouldn't exist. And if they didn't exist, people wouldn't have insurance coverage. So we can't really me as a therapist, I cannot create an evaluation, a plan of care, create a program without understanding the financial impact to the individual. So yesterday, I did an evaluation on a lady. Let's call it a pre-op eval. She was pretty much sold she's gonna have surgery no matter what. She has a $40 copay. She is not working. She's living on a fixed income. She cares for her grandkids, you know. $40 is a lot of money. It doesn't make sense for her to come see me 3 days a week, pay me $120 a week out of her pocket. She couldn't afford a higher monthly premium with better coverage. She certainly can't afford $120 a week, right? And so I take that into account when I develop her program and I look at the resources that I have around. So I could say, Mrs. Patient, here's the deal. Do I think you absolutely would benefit from my plan of care and the treatment, the exercise, the functional training, all of that? Yeah, 100%. Like, she responded so well to the stuff we did day one. But I want to be mindful of the cost. If a therapist doesn't, I really think that's why so many patients just quit coming. Not even because they don't like what they're doing, and it's certainly not because they don't care about their health. People say that all the time. I've never met a human being that's like, ugh, I don't care about my health. No, like, it's because you don't understand, hey, that person had a $40 pay $120 because they need to put food on the table. So when I created her program, I said, okay, this is the most important thing you need to do. Do this at home, do this every day, just repeat this intervention, and see me in a week. If you're feeling good, we'll push that appointment to 2 weeks or 4 weeks or 6 weeks. You don't need to be in here every single day. If you don't want to do it at home, but you want to do programming somewhere, you can go to Planet Fitness. It's $10 a month. They have all the equipment there, right? Like, is that as good as being here with me one-on-one? Probably not. Not because I'm better than Planet Fitness. We certainly don't have nicer equipment. It's because I know how to get somebody to do what they need to do, but that's not a covered service. That's not what insurance is paying for, and that's not billable to insurance. So we have all of these moving pieces that we have to understand, we have to put together. We can't do that and I'm not picking on you, this is every student I've had for 20 years. If you, as a person in healthcare, if I say to you, explain insurance to a 6-year-old and you struggle, if I say explain a deductible, a copay, coinsurance, a premium, and you struggle, if you can't really, you internally understand what the role of insurance is, like, we are illiterate when it comes to the finances for ourselves, you know? So how are we supposed to help these individuals when finance is such a big part of it all? That's why I try to go through and, like, we look at the website, we look at, I usually use ehealthinsurance.com, and I pull up a list of premiums, and I look at plans, and I'm like, look, this plan has an $8,000 deductible and a $432 monthly premium. This plan has a $6,000 deductible, but a $497 premium, right? And it's just no copay, higher monthly premium. Less, you know, this, more that. It's a balancing act. It's all objective. So with all my students, I do that. With all my students, I look at, and you might know some of this, but like, we vilify insurance companies for turning a profit, although that profit comes back to us in the form of our retirement. But even that, like, do you have any idea off the top of your head, and I don't expect you to, what the profit margin, what's the net profit for a company like Apple compared to a company like United Healthcare?
I mean, I would assume that Apple is much higher than the insurance company.
So I haven't looked recently, but let's say 22%. A company like Coca-Cola, 26%. These are net profit margins. Put it in perspective, you know, a company like Kroger or grocery stores are like 1.5% to 4%. Most of the health insurance companies now, or at least the last time I checked, have been like 3 to 6%. You know, so why are we not vilifying Apple and Coke and McDonald's for crazy high profit margins when these insurance companies are barely making profit margins? I know some of the people say, well, they're bloated and they have fat systems and they're paying their CEO 20 million, 100 million, whatever. Yeah, but so are the other companies. You know, like, it's a for-profit company, and the for-profit goes to you and I. It goes to anybody who's got a license to provide services. We lose sight of that. You know, we think that there's some guy with a mattress that's 20 feet deep and he's stuffing all this healthcare money into his mattress.
So my struggle with that is,
Yeah.
so I go to McDonald's,
Yeah.
and I know that I'm paying $1 for my coffee and 30 cents for my vanilla.
Uh-huh.
And I know I'm going to Apple and I'm paying $9.99 for my phone.
Yeah.
But when I go to buy insurance, it's like, what am I really buying? And then when I go to a provider, they're charging $400 for this service, but then I don't really even know, like, break that down for me and let me know what that is. And then I also know that the insurance company isn't going to pay the $400, so that's where I don't trust an insurance
exactly.
company.
It's
and I tend to trust McDonald's because I can go get my coffee every time for $1.30 and be happy. You know what I'm saying?
Yeah. Yeah, and that's the financial literacy. You know, that's the person. I mean, I really think there's still people who are like, well, I don't want to put my money in this bank because I can't see it and I can't feel it and I can't touch it. And people who want cash and don't want to use, you know, like Venmo, because the cash is something they can feel. Like, these are lack of transparency, lack of trust in the system to know what's going on. Totally legit. But that's where you have to take kind of a step back and be like, these are my insecurities, you know, and my insecurities are costing me missed opportunity, missed income, because why? Like, why do I still have this stuff? You know, for me, there's stuff, I can hear it in my head. My mom said, you know, don't do this and don't do that and go get a job and, you know, get like that kind of stuff. We're not in that economy anymore. And that kind of stuff, while we can learn from it, it just doesn't apply. But the goal is, and you as an assistant, you're even in a more challenging position, I think, because at least the PT can be in the room, can be with the patient day one, can establish the plan. You as the assistant, depending on the environment, you don't have the control to change the plan. So when Mrs. Jones says, hey, I can't do this, this is too expensive, you know, what do? You do the best you can to give them a home program and that, but there's plenty of clinics around here. Like, it's standard. If somebody comes in with Anthem insurance, they get 6 units of care. I don't care what their condition is. I don't care who they are. They get 6 units. If you don't give them 6 units, you're on the chopping block, because Anthem will pay for 6 units. You know, like, again, we know Medicare is reducing reimbursement. I can't fight that. I can't ethically say, no, we need to stop that, because I know the abuse and I know the misuse and our own ignorance. That's the big part within our profession. We clean our own backyard up first, then I feel like I can go out and say, no, we deserve more. You know, but the fact is, we're still getting paid for so much that we don't deserve to get paid for, that I think we have to take accountability internally. We have to look at our own practices, look at what other clinics are doing, look at what we're doing, and say, no, like, this is not reasonable. And just the simple fact that I can take a Medicare beneficiary, I won't get into this part, there's a reduction called MPPR. So if I do 2 units of therapy, say 2 units of exercise, the second unit is reduced by a certain amount, because that amount goes to paying for, like, utilities and overhead and the cost of the clinic, right? So whether it's 2 units, whether it's 4 units, the first highest relative value unit gets paid at the full amount. Everything else gets reduced by MPPR. A typical 4-unit session, it's about a 24% reduction. Okay, so if I was gonna see one Medicare beneficiary for 4 units, right? Let's say full allowed amount is 100, I'm gonna actually get 75, because MPPR will reduce the 3 units. But if I saw 4 Medicare beneficiaries in the same hour of time for 1 unit each, I remove MPPR reduction, because each one's only being billed 1 unit. My reimbursement went from 75 to 100 for the same hour, the same 4 units, the same documentation. I'm documenting units. I'm not documenting differently because it's different patients. I would make the argument that we have the space, we have the facility, the equipment, everything. Like, do I really need 4 units with a Medicare beneficiary in many cases? So I could go from a 75%, increase reimbursement by 25%, 0 change to the amount of work, the amount of effort, the amount of time spent. It's a win-win-win. Does that make sense? Nobody does it. Nobody does it. You know, and I don't hear anybody talking about it. And I'm not even saying, like, you hear these strategies about, well, you bill therapeutic activity because it's $10 more reimbursement than therapeutic exercise. And it's not even a strategy like that. It's just simple, look, the Medicare beneficiary for 15 minutes of my time one-on-one, do they really get that much more benefit if I spend 60 minutes one-on-one versus 15 one-on-one? And if I'm doing 1 visit a week for 4 units, what if that same, let's say I didn't even reduce utilization, but let's say I did 4 visits with that same individual in a week for 1 unit each, right? Same utilization, 0 net difference in terms of reducing utilization, but now I've got 4 exposures. If I tell you something 1 time and I don't see you for a week, versus telling you the same thing 4 times, you're probably going to understand it better. You know, so, like, there's so many ways to look at this. You can't get creative unless you understand the guidelines, understand the systems behind it. But again, I don't see it. I don't see anyone in our world putting effort, energy into saying, look, guys, hey, check this out. We can 75%, we can increase 5%, and you don't have to do anything different except change the way you think about patient care. You know? And so.
Wow. So how come up with that? Like, what information did you get, and how, just through your own billing reimbursement, looking at
Yeah, I mean,
things,
it's
figuring
the
out?
same analysis we use as a therapist. You come in with a shoulder problem, I watch the way you move. I think of the anatomy of the shoulder, I think of the mechanics, I see what you're doing, I listen to the problem that you have. Tony, every time I reach in the back of the fridge to get a gallon of milk out, the front of my shoulder hurts. So immediately, there's the problem. I'm thinking biceps tendonitis, right? When you come in as a clinician, you're like, look, we're getting referrals, we're getting patients in, but the profitability isn't there. And Medicare is reducing reimbursement by 25% and 9% respectively based on this, that, and the other. So, okay, here are my resources, here are my tools, here's your problem. How can I create a solution for that? Question things. Why? Why are we doing an hour twice a week? Do we need an hour? Do we get that much more benefit from an hour versus a half hour? You know, like, those are the things. And there's therapists that are like, I need an hour one-on-one with the patient because I do this, that, and the other. And okay, so that's your thing. That's your thing. That's what you believe as a profession, as a professional is important. You're welcome to your opinion. That person's a therapist, I'm a therapist, we're on equal footing. I'm not gonna tell them they're wrong, right? Therapists who work for me, I would never do what they do. But as an employer, the way I view, they're a professional. They're licensed. They're not a technician. They're not, a line worker. So I'm not going to tell them how to do their job. If I really disagree, if I think they're doing something wrong, harmful, I'm going to fire them. But at the end of the day, when I have clinicians that have a different treatment approach, they're entitled to their treatment approach. They spent just as much time, money, effort into learning it. As long as their patients are getting positive outcomes, they're going to succeed. So from that perspective, I don't impose my will. My job as the business owner is to run the business, to create a platform that allows them to do what they do best. My customer as the business owner is you, the therapist, the assistant, the therapist, whoever is working for me. You are my customer. The better I take care of you, you can do your job better. You take care of the client. The client just happens to pay me, and then I flow through and pay you. So I totally lost what we were about. What'd you ask?
I don't know, because that went to a good place. I liked that. I'm so about taking care of, my dad had a commercial printing company for 30 years, and it was all about taking care of the employees.
Right.
I mean, he paid those people more than any other place. They had amazing benefits. I mean, and he kept people for 30 years,
Right.
I mean, so that's a huge aspect of running a business. So
Yeah.
and I kind of forget where we went.
Yeah. That's all right. Oh, you asked how I came up with that stuff.
Yeah. Yes.
I think as therapists, we just love problem solving.
Yeah.
That's it. And when you're problem solving, it doesn't matter if it's an orthopedic issue, a neuro issue, a finance issue. You look at the problem, you look at the tools you have available, what's in my toolbox, and I create a way to get from point A to point B. And then I do it, and I test it, and I'm like, oh, that was terrible. I got to figure out a better solution for that problem. And I'll tell you, it has to match the personality. So I can create a very viable, financially successful solution to a problem. I cannot use the same solution that works for me for you. Because you're going to have different biases, you're going to have different prejudices, you're going to have different ideas and concepts, and there's therapists in my groups that I don't know what the word is, but they absolutely disagree from a patient care perspective with me, and that's totally fine. They need a different solution to get to where they want to be, because probably like your dad, certainly like me, I'm not in this to maximize profit, to maximize income. I'm in this to pay for everything else. I run the business to provide my support. I don't need a nicer house. I don't want a newer car. I want to be comfortable, I want to be secure, and I want time with my family. That's why I do this. If I was a CEO, hired to maximize profits, hired to make the balance sheet look good, that's what I'm going to do, right? That's a different game with different rules and different measures. But most private practices, that's not the game that we're in. We want to treat patients because we love treating patients. We want to feed our egos because therapy is off the charts with ego, me included. But the business is just there to support the stuff that we want to do, you know, because if we really wanted money, this isn't what we'd be doing. I just posted in my Facebook page the other day, I was like, I realize none of us went into therapy to be rich, but I also think none of us went in to be poor, you know, and so we've got to find that balance, and this is where it starts. It starts with you understanding insurance, you understanding private pay, you understanding what should be paid for by insurance and what should be paid for by the individual. So last thing, and then I'll wrap this up. This is a long Facebook Live or Google Live, YouTube Live. This is an interesting concept. So the gentleman, without saying names, who comes in at 8:30, right? He has insurance coverage. I did an evaluation that was a covered service by insurance. Now, you have been working with this individual, this patient. He lives independently in the community. He drives himself to therapy. He cleans his gutters. He mows his grass, right? He dresses himself, bathes himself, feeds himself, manages finances himself. He still has hip pain. He still has issues. He's still unsteady when he's walking in. Before you came, he fell in the parking lot at the post office. So he has issues. Honestly, and you're not offending me if you say yes, do you really think that individual would benefit significantly more if he was working one-on-one with me as a therapist versus what he's doing, which is a self-pay wellness program, coming in twice a week, working out with our general supervision? We give him direction, we kind of tell him what to do, but it's not covered service, it's not therapy. Do you think he would do significantly better if he was one-on-one with a therapist in a covered treatment plan versus what he's doing right now? No. But all day long, I see therapists who are like, well, this person just fell. They absolutely need therapy. This person is, frail, geriatric. They absolutely need one-on-one. No, they need reps. Like, the purpose of covered insurance therapy services is it requires the skills of a therapist. Now, if he was medically unstable, if he was at risk for a stroke or a heart attack during the exercise program, and we're monitoring those things, yes, needs the skills of a therapist and assistant. If he had an unstable, unhealed fracture or open wound, yes, that's where we come in. But simply because he won't do it if we don't make him do it, simply because he doesn't have a place to do it at home, those do not make that a covered service. And I think we are so passionate about what we do. We know how important it is. We project kind of our biases on that. We're like, absolutely, this should be covered by insurance. No, it shouldn't. But if we don't understand the guidelines and we don't know the reference, like you right now, but you will, couldn't go to a reference. I'm asking actually, could you go to a reference right now and be like, look, this paragraph on this page clearly states this is or is not covered by Medicare? I'm asking you as a student, can you do that?
I don't know.
Yeah, I don't expect you to. I couldn't do it when I was a student. But there's absolutely a Medicare reference, CMS Chapter 15, Section 220, medical necessity. There's a page, a paragraph you could go to and reference if you said, this is why I made this decision as a therapist. There's my reference for it, But I think therapists would be hard pressed to find those references. Now, the irony is they could probably give me 50 references for why they believe dry needling is an effective strategy or not. They could give me 50 references for why, you know, we treat sciatica in this fashion and with this intensity and this level and all of that, which is awesome. I'm not taking away from that, but we need the other side. And if we're in a system that relies on Medicare reimbursement, you need to understand those guidelines. Because Medicare is my employer. Medicare has hired me to deliver something, and I need to do it based on their guidelines, or they should fire me. They wouldn't pay me. If I hire a contractor to build a kitchen and he builds a bathroom, that's not what I hired you for. You know, and don't tell me it's a kitchen because there's a sink, right? Like, I don't want a toilet in my kitchen. That's what we do. That's the therapist who does dry needling on a Medicare beneficiary and calls it manual therapy, even though if they go to Medicare and they say, do you cover dry needling? Medicare says no, definitively. They say, well, I'm using my hands and I'm manipulating the tissue and I'm also doing manual therapy while I dry needle. Yeah, but you're doing dry needling and you're calling it and billing it manual therapy. You know, like, that is not what Medicare is paying for. So, so many of those things, and that's the stuff that I obviously get excited about. That's the stuff that I wish we could bring into the programs more, help the schools. Like, they can't cover everything. They have to cover what's on the boards. They have to cover what's required. But I do think there's an opportunity for supplemental services, you know, more information that could come in there. But
even at Sinclair, there's a professional issues class, and it's, you know, it's spread out over, I don't remember if it was an 8-week or a 16-week course, but there's room in that course even for stuff like that. It would be awesome.
I think it's hard because they don't know if you're going into acute, neuro, ortho, inpatient, outpatient. Like, they have to, pediatric, geriatrics, they have to cover everything. Yeah. It would be nice if there were tracks that said, hey, I'm probably going to go this way. I know I need to know some of that stuff, but let's have like a focus for those people who want to go outpatient ortho, you know?
Yeah.
But